Hey everyone, Rupesh Patel here, host of the Two Nobodies podcast, and you're about to listen to a conversation with Janet Davidson. Janet has a legendary career across Canada's healthcare system. She's currently the head of the Nova Scotia Health Authority, but she's led health systems across the country. And she's definitely the person to talk to about Canada's healthcare system crisis. We talk about workforce issues, for example, the physician shortage. What do we do about that? To nurses, to other healthcare professionals, to folks who want to immigrate to Canada and what are the considerations that they ought to make. We talk about the leadership challenges of working in the healthcare system, to what's going on with loneliness. There seems to be this loneliness epidemic, but what can the healthcare system actually do about something that seems to be so perhaps individual? To focusing on the social determinants of health. It seems like that's just a theory, but how do we make that really practical and operational and integrated into our system? It's a really cool conversation. If you're someone who's fascinated about healthcare systems in general, and particularly in Canada, this is the podcast for you.
Welcome to the Two Nobodies podcast with my dad.
Well, hello, Janet. Good, so nice to see you. And I'm really excited to have this conversation. It's been something I think about for a while. I wasn't sure if we were going to be able to connect, and I think we set this up probably maybe in November or October, and it's already April. Time flies. But welcome to the Two Nobodies podcast. Really appreciate having you this morning.
It's really good to be here. I'm quite pleased about this.
That's great, Janet. You have, well, we were talking about it earlier. I don't know how to say this, but you have a lot of years in this system. You know the system so well. I'm just so excited to share your experiences and your thoughts with the audience. Uh, why has healthcare been a place that you've just found home?
Well, it's a good question. I would say some of it originally was, at the time I graduated from high school, there wasn't really a lot of opportunities for women. It was nursing or
Mm,
teaching.
mm,
And when I'd been in school, I'd been a volunteer. I was at Toronto and I was volunteering at Princess Margaret, which was a cancer hospital in Toronto. And I really got quite engaged as a volunteer in the work that they were doing. So when I was about 17, made up my mind that what I was going to do was go into healthcare. And at that point, it was nursing. So when I graduated, I went to King's College in London, England.
mm-hmm.
Wanted to escape my family, and just a teenager, you got to get
Yeah.
away. So I moved to London and did some of my training in London, England, at King's College Hospital, and then came back and finished it in Toronto. And from there, I've nursed for a while. I taught nursing for a while, and then I did a graduate degree at Alberta, and then got into healthcare management. But it's always been, there's probably been one of the big motivators in my life is to make a difference, a positive
Mm,
difference. And also, I would say the other one would be to learn. And I think healthcare brings both of those. One, you can make a positive difference in the lives of other people, both
yeah.
those who you work with and those who you're caring for. But also, the body of knowledge in healthcare changes so rapidly that you're always learning something new. So it kind of was a come together of a whole bunch of things that caused me to stay in healthcare. I mean, I've been lucky over my career because I've been in healthcare over all kinds of changes, and I've worked
Mm-hmm.
in a lot of provinces and other jurisdictions. So I've been able to get quite a blend of different experiences, which I think reinforce my interest in and commitment to healthcare.
What was that transition like to go from more on the clinical side and working with like the individual to then, like you said, you did that graduate degree and got into more like the healthcare management side of it. Was that a hard transition for you, would you say?
N- I don't think so. I think one of the reasons probably why it wasn't such a hard transition, and I've said this to other people, that one of the things I value most about my experience is that I'm a nurse by background. And
Mm,
so I understand the clinical practice of nursing. And when I was in undergraduate school, of course, I did public health, so I got that as well. But I think moving over into the management side, um, and I hate to kind of put them in those polarities, this side or that side, but I think uh, from a practitioner point of view, understanding what some of the challenges were, then being in a position in management to be able to do something about it. And when I graduated from graduate school at Alberta, I was lucky. I went to the government to do some residency training, but then I went to the university hospital.
Mm.
And so I was lucky to have Don Sherman. He's no longer with us, but Don Sherman was my first CEO, hospital CEO, and he was just brilliant, absolutely brilliant, and a mentor. And I think that made a big difference to me. You know, it was never that you can't do something; it's how do you do it in a way that's reasonable. And the focus always for him was always how is this in the best interest of the patient? And so that really resonated, and I was able to make the transition quite smoothly, I would say.
Were there some barriers for you just being a woman and entering into leadership in the healthcare field, or was it a male dominated kind of place? Or yeah.
Yeah, people have asked me that before. I've actually never experienced that.
Hmm.
When I went to Toronto, moved back to Toronto from Alberta, became a CEO, there were a group of women CEOs who got together regularly. And I know some of them had some challenges, but I never experienced that. Now, I
Hmm.
certainly, when I look at the data and see, there's no doubt at the senior management level, it's male dominated, which is interesting given that the workforce is, probably 90% plus female. But I think for me, it wasn't a big challenge. I think one of the other things is the graduate degree I took from Alberta um, was a was about management. It wasn't about,
Hmm.
one of the challenges I think some of the nursing did at the time that I was practicing nursing. The encouragement was to do a graduate degree in nursing, but it was clinical. So,
Yeah.
I could get a master's degree in critical care nursing or a master's degree in obstetrics or whatever the specialty might be. I didn't want that. I'm not saying that's not good, but I didn't want that. And so to get management, you actually had to kind of go outside of the more traditional boundaries at the time to do it. So I came into management with a more broad business-based background than simply clinical.
Do you think that kind of helped your credibility to some extent because you had that sort of maybe outside view of management?
Oh,
Or
I think so.
yeah.
I think the combination of both understanding the management side of it, but also understanding the clinical. I've often said that I really don't think when you look at leadership in healthcare, and I always say we confuse leaders and bosses. We have a lot of bosses. We don't necessarily have a lot of leaders, but people thinking that anybody can be a leader in healthcare. I'd say that's not the case at all. I'm not saying anybody with the appropriate training and experience and everything else can't do that, but to just simply say, well, I've got a graduate degree in business and I've run a petrochemical plant and now I want to be a CEO of a healthcare system. They're not. I don't think they're interchangeable that way.
So what would you say are the unique characteristics then of being a leader in healthcare compared to an executive leader somewhere
Yeah.
else, I guess?
Well, I think a couple of things. One, in healthcare, it's all about collaboration and partnerships. I mean, you
Mm.
can't do it without whether it's from organization to organization, or whether it's individuals working together. There's the success. Your success in healthcare is the extent to which you partner effectively with other organizations and other people to improve the health and well-being of the population and the workers. And I just think it's different. I don't think that it's means you don't need some of the background and experience that you get in a more general management role. But I do think without understanding what healthcare is all about, like I often say, you wouldn't have. I use the analogy in governments. You wouldn't have a deputy of treasury not having an accounting background,
Mhm.
or you wouldn't have a deputy attorney general not being a lawyer.
Right.
These are pretty straightforward, but to say that, but a deputy of healthcare can be anybody. I don't, I don't think that's the case. I mean, I'm just using that as an example, but I think
But that happens though, right, Janet? Like a lot of
no,
deputies of
no, it
health are
does.
not.
It's
Yeah.
well, I think the it isn't. It's not public service now. It's civil service, and I
Mm,
think there is a difference in the use of those terms.
okay.
Okay. But I think it's a job, so you will get people. I'm not saying they aren't trying to do the right thing. They are obviously hardworking and committed, but to say, I'm going into, say, the government, I'm going to be there for the rest of my life. So I can be, an assistant deputy minister of highways one day and an assistant deputy minister of healthcare the next. And I would say that that's not that you don't need to understand government, but I say not understanding the content, I think, can be a problem.
Interesting. Yeah, because I know that they nowadays it seems like at least at the deputy level, they're wanting to make them sort of like CEOs of everything. Like they can plug and play
Oh,
them in
yeah,
any department as long
absolutely.
as they're effective CEOs kind of thing. That's the most important quality. But what I'm hearing is in certain areas, perhaps having that content or that subject matter understanding can
Yeah.
really be beneficial.
Well, a classic is look at Boeing. And the
Mm,
criticism of Boeing now. I mean, the CEOs of outstanding individual business. Up until that point, the CEOs had been engineers who actually
yeah.
understood what the work was. And so now there's talk about, do they need a different CEO who will bring that engineering uh, know-how, which is really what gave Boeing the leg up.
Hmm.
So I think it's not either or. You need a combination of both.
Do you think it's a challenge or do you think it's a benefit if the political mass, if the minister that a deputy or a healthcare executive is serving has a health background? Do you think that's a benefit or do you think that can be a bit of a deterrent or
Well, I think from the point of view of a CEO, I think it's important. I think from the point of view of a deputy, I think there's some benefit to having knowledge of the healthcare system. I mean, we're lucky, for instance, in Nova Scotia, our minister's a former nurse, and so
okay?
she understands the clinical stuff really well, and
Yeah.
and she understands the challenges and opportunities. I'm not saying that you necessarily need that in a minister because there be political. You look Monique Bejan, she certainly wasn't a nurse when she was federal minister. I think there's, on the other hand, Jane Philpott, when she was Minister of Health
She's a
federally,
doctor.
a
Yeah.
doctor. So
Yeah.
I think understanding, some of the of what it's all about is good. But you can, to some extent, if you've got the right supports around you, you can make it work. I think the challenge is if you come into something like that and because of the virtue of your position think you know it, and so
Mm,
you have the answers without actually really understanding what the problem is.
yeah. Do you find, I don't know if anymore, but do you find yourself sometimes still drawing back on those clinical times as
Oh,
a healthcare
absolutely.
executive? Yeah.
Absolutely. I mean, I still, even as I sit on some, well, I chair the board here of the Nova Scotia Health Authority and sit on the board of Sick Kids and some other organizations that are in the healthcare space. I mean, I think for me, I always still ask myself, how is this whatever we're talking about, how is this in the best interest of the patients and the community that we're supposed to serve? So for me, it's been very helpful.
Yeah. Yeah. Cool. I wanted to focus first. I know we're going to talk about different elements of the system,
Yeah,
but something I've been thinking about more the last little while, especially post pandemic, is loneliness.
yeah.
It's something that some really important figures have been talking about and almost calling it an epidemic. I'm not sure if
Right.
that's the right word, but it seems like it could be. I'm just going to share a video for folks and for
Sure.
yourself. It's with Vivek Murthy, who's the U.S. Surgeon General, and he wrote a book on loneliness. And I'm just going to pull this up for us here. Um, and then maybe we can have a bit of a conversation here.
Loneliness is far more than just a bad feeling. Being socially disconnected, which can range from feeling alone to being isolated, is bad both for individual and societal health. Research shows that loneliness and isolation are associated with a greater risk of heart disease, dementia, stroke, depression, anxiety, and premature death. In fact, lacking connection can increase the risk of premature death to levels comparable to smoking daily. Loneliness and social isolation are also far more common than we might realize. About 1 in 2 American adults report experiencing loneliness. Everyone can be impacted across all ages, socioeconomic conditions, and geographies. This widespread disconnection presents profound threats to our health and well-being. Social connection is as fundamental to our mental and physical health as food, water, and sleep, and it affects our performance and productivity at work, school, and in our communities. Now is the time to invest in building social connection. This first ever Surgeon General's advisory on our epidemic of loneliness and isolation shows us how. The keys to connection are simple. Answer a phone call from a friend. Invite someone over to share a meal. Listen and be present during conversation. Seek out opportunities to serve others. These steps may seem small, but they're extraordinarily powerful. By strengthening our relationships, we can improve our heart and brain health, reduce our risk of diabetes and high blood pressure, boost our immune systems, and lower our risk of depression. We can build lives and communities that are healthier and happier, and we can ensure our country and the world are better poised than ever to take on the challenges that lie ahead. Visit surgeongeneral.com.
I always love, I don't know if you've listened to Vivek Murthy speak before, but he just has this very calm demeanor about him.
Brilliant.
Yeah. So, like, fostering connection, we need to all think about how to do that. It seems like there's some, he talks about some very specific actions at sort of that individual level. But from a healthcare system perspective, this is where I may be challenged in thinking about this. Is there anything we can do at a system level to perhaps sort of foster connection and address some of those actions that he's talking about?
Well, I think we can. I mean, I think for example, if you look at COVID, some of the stuff that was done during COVID, and the concerns expressed by parents, families with children being isolated, and their only relationship was with a computer or some sort of a device, or you look at what seniors in long-term care facilities isolated completely from family and anything else. I think there are things that we can do. Those are, I would say, that they're factors that need to be explicitly brought in to the planning discussions when we talk about what we want to do.
Hmm.
So, how do you support that? In Europe, particularly in some of the Nordic countries, they talk about patients and families being co-producers of value in the health system, co-producers of value. So
Yeah.
they are, it's just part of the way they do their thinking and their business, that looking at how you bring the community and the families, and I use families broadly speaking, into helping support and nurture individuals. The UK is doing some wonderful stuff too about what they call family visiting, where they have the whole community is engaged in looking after themselves. So I think there are a lot of things that the healthcare system can do. The challenge is we talk about a healthcare system, but we're really not. We're very isolated and we're
Mhm.
fragmented ourselves. And so, it's not a healthcare system, it's a sickness system
Yeah.
where it's the only, I've often said, it's the only industry where we actually don't really look out the door and say, where are these people coming from? We do notionally, but, you look at a box of Kleenex. I mean, Kimberly Clark wouldn't develop the box until they looked at, what the public's view was of colors, of all kinds, shapes, you name it. We don't do that, and so uh, when you get sick, we want to make sure that if we treat you as fast, appropriately, efficiently, and all of that other stuff that we talk about. But what makes a person is kind of secondary to all of that.
Yeah, it's like you treat and then out the door and you move on to the next patient, right?
Absolutely.
There, I know I have a friend who moved to Germany, and they said that um, she was contacted within months about like, hey, it'd be good to find you a physician, or anyways, the system connected with her, and she was just shocked. And I think, like, I don't know if culturally that would resonate with folks here in Canada, especially from a post-COVID world, but but it just seems like they understand there that, okay, there needs to be this follow up, there needs to be some connection to the system. um you're not just completely on your own as an individual, that somebody is looking out for you and caring for you. Like, I imagine that makes a difference.
It does, absolutely. And if you plan and organize services around, or supports around, what is it that makes and keeps an individual healthy?
Hmm.
If something goes wrong, fine, you deal with that, and that our system is so-called system is supposed to do that. But it's nested in a bigger picture. And so, it's not just, Mary's had her hip replaced, throw her out the door, and I'm overemphasizing to make a point, but the fact that Mary's now going back to a community where she's got her friends, she's got a library that she used to go to, or she, every 2 days goes down to the local coffee shop with her friends and all this sort of stuff. How do you actually connect? What is it that
Yeah.
makes these individuals successful and healthy in their own community? And it's not the acute care services they got when they needed some surgery
So
or whatever.
so on that, how do we collectively orient our healthcare system around something like the social determinants of health? So, for folks who don't understand social determinants of health, we're talking about creating economic stability, neighborhood connection, access and quality of education systems, and healthcare, all that. Like, how do we? Because I imagine it's not just a provincial thing. Like, this would have to be a national sort of collective effort. But I've never really, all I hear from social determinants of health are from the academia side, from people talking about in theory, but I don't know if there are case examples or practices of really orienting our system around the social determinants of health.
Well, it was interesting. One of my first ADM jobs in Alberta was ADM of population health.
There you go. Okay.
And so in the 90s, there was a big push. It was kind of the renaissance of somebody pulled Mark Lalonde's 1973 book off a shelf and said, oh, wait a minute, maybe there's something here we can do. And, we set up, there was an interdepartmental committee where anything that broadly impacted on health, whether it was the quality of the water, the air, education, housing, you name it, there was a committee that looked at it, and you didn't advance any policy going forward unless it had a review and sign off by the
Mm.
related ministries. It didn't last that long, unfortunately. I think for a couple of reasons. Number one, it requires what we call a whole of government approach. Government is as siloized as any other,
Oh my God.
you know,
Yes.
as
Yeah.
anything else is. So, I mean, a perfect example would be you look at housing for mental health. Well, health systems concerned about mental health, housing is in another portfolio, and trying to get money moved from one portfolio to another through Treasury Board is not an easy thing to do.
Hmm.
So I think there are barriers that just by the structure itself, uh, uh, and doesn't necessarily have to, but the structure supported in the absent. Well, despite the evidence, which would suggest there needs to be more fluidity there. But I think two other big things. One, there's no accountability for social determinants of health. I mean, again, when I was ADM, the regional health authorities that were in Alberta, they had uh, other determinants that they had to measure and report on, like low birth weight infants, like housing, like child feeding programs. There were things there that caused them to look at a broader picture than simply put, but the number of surgical procedures you did or the number of births you had. There were Smoking was another one that we focused on. So there were
Yeah.
a number of things that way. But the other big one, of course, and governments work in 4-year cycles, and all depending on which government you happen to be in, they can be at odds with each other. But you don't see the results. There's an urgency now about I got to make sure that I'm doing something that the public sees right away. Either I can put up the sign that says, this building has been built courtesy of the government of whatever,
I've
or
reduced wait times
yeah,
or something
or
like that.
MLA. Not that they're not important,
Yeah.
but the things like child feeding programs, these take time. They're not going to be done overnight. And most, the political time cycle, it requires a lot of courage. I mean, I remember when I worked internationally for a while, there was a Nigel Crisp, Lord Crisp had been a Minister of Health in the UK, and he said to me one time, he said, Janet, um, true transformation requires courage and leadership. And then he patted me on the back and he said, and trust me, my dear, they're in very short supply.
Mm-hmm.
Because it does. You look at what Tommy Douglas did.
Yeah.
I mean, that required a hell of a lot of courage and leadership to do that.
Yeah.
That's not something that is in big supply nowadays. It just isn't, unfortunately.
No, and in many cases, like sometimes the federal government wants to show leadership in an area, but I find sometimes it can be short. Like if you think about the climate side, this current government in 2015, they brought in the Pan Canadian Framework on Climate Change. Great. That's, mobilize all the premiers towards some sort of action, but there was no real concrete plan to kind of continue coordination. And now all the provinces are kind of fragmented and don't agree with the approach anymore or that sort of thing. How are we going to move to a national climate target if we're not all coordinated in a federalist system, right? Like I would think same thing, healthcare related, like the federal
Absolutely.
government is willing to throw money at mental health or on the housing side, we're seeing challenges where provinces are like, I'm kind of concerned about the federal government getting involved in housing. Well, they're not really doing anything about housing, and federal government wants to. Like, anyways.
It's no, I agree with you. I think I've often said when people are asking me about coming to Canada and the healthcare system, I said, first of all, you have to understand there isn't one system in this country anymore. The vision of Tommy Douglas is long gone.
Yeah.
Medicare, even this, they talk about the fundamental principles of Medicare. Those don't exist. I mean, there's portability. You can't just go to another province. And in some cases, the provinces will have different arrangements. And so I think, I think for whatever reason, I mean, provinces now are much more independent than they've ever been before. And, their view is just give me money and then shut up and go away, and I'll spend it however I want to spend it, which I can understand to some extent. But the point is, you won't get any national thing. Even the accords that have been signed on healthcare, they're the accountabilities are pretty vague.
Yeah. So do you think the any approach towards addressing the social determinants of health are kind of a pipe dream, do you think then? Or
Well, I think they could be done provincially. I mean,
yeah.
I would say rather than looking, if the feds try to intervene now in healthcare in any sort of substantive way, I think there'll be pushback from the provinces, and
100%.
and
Yeah.
that's the way it's going to be. But I think there's nothing to stop a province from doing some things. And I mean, a few years ago, I was reading about something in New Brunswick, where a community in the francophone section of New Brunswick decided they were really going to look at some of the social determinants. So they all got together and they looked at things like housing,
Hmm.
they looked at education, they looked at um, community development, all of these sorts of things, and they did their own thing. So I think engaging communities. Certainly, when I lived in Ontario and Mississauga, we did some stuff around, how do you create a healthier community? So, what are the walking, cycling paths, for example? These are
Mm.
things we can all work together, or can we, hospitals that are interested in cardiac disease, working with the Y to have better exercise programs. I mean, I think there are things that can be done, but I think the ability to do, maybe I'm just being a little bit pessimistic, but I think to get some big national thing is going to require more effort and more commitment than there seems to be. And the answer, I'm quite frankly getting tired of that. The answer is you just give us more money and everything will be fine. And I'm certainly quite vocal about that. This is one case where I say thank God for the United States, because they spend more per capita than we do
Mm.
on healthcare. So we're second to
Mm.
them
Wow.
on the amount of money. We rank in the bottom quartile for performance. So obviously, money is, you look at the per capita spending in Europe and some of the stuff they do, and their outcomes are better. So it's not about It's not about more money; it's how we're spending the money.
And I think that's like I would imagine from the public standpoint, it's like let's throw more money at the problem from political perspective, throw more money at the problem, and that's where I know when we talk about different elements of the system today, that's something I want to focus on is like from a solutions perspective, what are those sort of non funding sort of solutions I guess that we could focus on. Very quickly though, you talked to when we talk about social terms of health, you're talking about like it would be great to have this sort of whole of government approach like you experienced when you're in ADM uh, in Alberta recently. You were seeing with Alberta Health Services, it's no longer going to be a whole of government approach kind of thing. It's being fractured.
Yeah.
Um, I don't know. Any reaction to that change? I mean, I guess in theory, I kind of understand why maybe they want specific focuses on mental health and continuing care and that sort of thing, but not having it under one. I mean, it took a lot of effort to merge the regional health authorities into one health authority, and I know that
I was
Ontario has recently tried to adopt that model in Ontario Health, and now Alberta seems to be retracting from that. So, and I know like from a I know there's been a lot of positive attention in the past about like Alberta has been a good model to kind of move towards. So it just seems kind of backwards to kind of split it up a little bit here. But any reaction
Well,
to
I
what's
mean,
going on?
I was certainly involved in Alberta before the regionalization, then the first regionalization, and then the Big Bang when all into one. So I've kind of seen the evolution. I think it was fair to say before the dismantling. I mean, Alberta Health Services was the most highly performing system in the country. The administrative costs were low compared to anywhere else in the country, and they had some of the integrated care that they are doing is quite was quite remarkable. I'm not a big as over the years I've been less and less enamored with structures per se. I think it's too easy to assume that a structure is going to solve your problem.
Sure.
But unfortunately, structures are easy to change. So, it's political. You can wipe them out in a minute.
Yeah.
But the problem with that is number one, you're telling the public that you really don't know what you're doing because you're changing something that you supported originally.
Mm.
And number two, you're creating a level of confusion among the people who work in the system that they don't need. But I look at a province like British Columbia, has really, I mean, they created those regions back quite a while ago now. They haven't changed them at all. I mean, they've done some tweaking, but they've left it alone. They're focusing on internally what do we do to get better performance, which is, I think, is the way to go. I mean, I'm dating myself, but in the late 80s, Alberta, under Ralph Klein, we did the Rainbow Report was produced. And it
Mm.
talked about some of the key issues. And a couple of the key issues was lack of integration and lack of coordination. They came up big, big time, and particularly with seniors, children, and mental health.
Mm.
And so they were drivers of the integration. So I was kind of interested to say, well, the rationale for integrating is now you're using as the rationale for disintegrating. So I think you can disconnect these groups, but the point is where you always have the barriers are at the point of connection. I mean, you look at this most recent incident in Edmonton with the patient being discharged
Right. Yeah.
to that. Well, now it's two different setups now. They're not. It's not all part of AHS. Once they go out the door, in this case it was the Royal Alec, I think. But once they're out the door, they're not. They're not part of the reconfigured AHS. So I think it makes. I think when we create structures, we have to look. Does this really? How is this in the best interest of the patients? That's really
Yeah.
what we think it's all about.
Yeah, and on that patient front, I don't know if this is the case, but if they're now not in the realm of AHS care, the system's potentially losing sight of that person, right? As a
Oh
whole.
yeah,
Yeah.
now you've got to worry about creating a whole bunch of connections that were there before. So I think it's a challenge. I don't think there's, as I said, I don't think there's anything um, that you look at where you say that a structure is going to solve your problem. Everything's going to be fine now. It won't.
I feel bad for the folks, and I imagine this exists at most health authorities. But I feel bad for the staff, like especially AHS. Like they've gone through so much change since 2009, whether it be changes in the board every year or changes in their executive leadership. Like I imagine it'd be really tough for middle management and for frontline staff to kind of go through all these changes.
Oh, I think so. And I think, I'd hoped during COVID in particular that the healthcare system would realize that it actually is a people business.
Hmm.
And you can't do anything without people. If you don't have people, you can't provide a service. That's it, point blank. And they have, I think, for years, for decades, we've often talked in healthcare. When we talk about our people, we talk about them in terms of their bodies that fill slots in a timesheet or collective agreements, not about the fact that these are without them, we can't. Not only can we not provide service, but how we think we're going to provide quality service. I mean, the linkage between quality of the service provided and the level of job satisfaction of the providers is quite well known.
Yeah.
And so if you get I mean, I think one of the things I've said about healthcare that's really probably one of its defining characteristics is most people who go into healthcare go into it because they honestly want to make a positive difference in the lives of other people. You don't see that in most industries. They're generally all aligned, whether it's the housekeeper, the registered nurse, the physician, you name it. So what is it? What is it that we're doing in the system that doesn't allow them to do that?
Hmm.
And creates this high level of dissatisfaction. But I think then, to turn around and then say, okay, we're going to throw everything up in the air. We're going to come up with some harebrained idea to do something, and then wonder why our people are leaving. Well, hello, they can go elsewhere now, and not even can they go elsewhere. They can go elsewhere in Canada, can move
Yeah.
around. They can go elsewhere in the world. I mean, in
Yeah.
healthcare, the shortage is international, and it
It's
ain't going
global.
to
Yeah.
be fixed in the next decade.
Yeah.
And so to think that you can do a few things that might like increase salaries, but don't bother with the working conditions, it's not going to work.
I was talking to a few physicians, and I imagine this extends to other healthcare workers, but they just feel really disrespected. Like there's this attitude coming from, and I don't know if this is just an Alberta thing or across the country, but the physicians I've talked to were in Alberta, and they just feel very disrespected with the way, like they're just sort of treated like this. They're like, we're highly qualified, highly trained, and we spend so much time in working with patients, and it's just it feels like we're just being written off these days. So I imagine like that would extend to other healthcare
Oh,
workers.
it does,
Yeah,
absolutely. And I mean, you hear it all around you look at some of the big GP walkouts in the UK, it's all about a dissatisfaction among that group. And I think it's right. You train people to do things, and then I mean, doctors often talk about the fact that they're absolutely overburdened with needless paperwork. Not that the system might not require some of the paperwork,
sure.
but it doesn't mean that somebody who's got 10, 12 years of experience actually needs to do that.
Yeah,
So
yeah.
I think they're probably right, and they're not the only group that feels that way.
On the AHS front, really quickly, what do you think Albertans should be looking out for, like going forward, as this sort of restructuring or sort of disassembling is happening? Like, what would you, if you're a resident, kind of be evaluating or looking out for?
Well, I'd look at the level of satisfaction, clients, patients, whatever. But I'd be looking at what are the what are the misses or the disconnects, whether it's in mental health, somebody's institutionalized and then all of a sudden has to go to the community,
Mm,
or children. I mean, any of the specialty stuff. Now that it's all split up, what do are there increased wait times? Are there levels of dissatisfaction? Are there misses? Are you like doing something where somebody is discharged and not followed up, or things like that? So I think it's going to be a lot of diligence around, how is the system actually performing, and is it actually cost effective?
Yeah,
and not just having somebody tell you it's cost effective, but having some good measures to be able to do that.
that's great. I know, Janet, you've worked obviously right now, even you work with a lot of political officials. What do you think political officials are getting understand well, and what do you think they're kind of missing out on, or what do you think? Yeah, what do you think they're getting right, and what do you think they're getting wrong from either from an issue side or a solutions perspective more broadly?
Well, I think they're, whether they like it or not, they understand that healthcare is a huge priority for their population. So
Hmm.
I would say, often jokingly, or not really jokingly, would say that I don't think there's an MP, an MLA, an MPP, or whatever the term is that you would call the elected official, um, that does not hear from a one of their citizens at least once a week, if not once a day, about something related to healthcare. So
Hmm.
they're aware that, more than they've ever been before, how important this is. I think what they're not as aware of is that this is not something that's going to be fixed overnight.
Yeah.
That you can't just do this, well, open this emergency department, or don't do this, or do this, or do that. These short-term fixes, can oftentimes cause more problems than they fix. But I think the other thing is that there needs to be, they don't understand the importance of accountability, and actually, stick to itiveness, as I would call it. This is a country of pilot projects. Let's just study this. Let's study this. Let's do this. Let's do that. We never actually do it. We just do a report and put it on the shelf. So
Hmm.
I think the need to, when you something is worthwhile pursuing, to stick with it and not say, okay, well, I want it fixed by tomorrow. I mean, Medicare's been around for decades, and a lot of the problems we have now were not created overnight, and they're not going to be fixed overnight either.
Yeah, I can feel though for politicians, especially in nowadays
Absolutely.
society, like um, we're in a society of instant gratification, right? And people want
That's
things
true.
done immediately. Like it takes a lot of courage for a politician to be like, I hear you. Like, for example, something like wait times, but this is not going to be an overnight fix. And now you have people who are like, well, I got this immediate issue that I'm dealing with, or I have a certain level of expectation that the system should be there when I need it. And that's reasonable,
It is reasonable.
but that's a hard conversation to have that I don't know if many politicians are willing to have.
Well, I think no, in some cases they're not. But it's also that we've not been, generally speaking, we're not very open with the Canadian public about what are the real faults of our system.
Mm, okay.
I was in Australia not too long ago, and one of the things that really impressed me, they are really data driven. So you'll have whatever they call them, out visiting a community, who says, well, we need an emergency department, and the MP will say, no, no, look at the data here. You don't have enough volumes to do this, because if you bring patients in here, they're going to die because you simply don't have the
Yeah.
expertise to do it. That takes a lot of courage too. So I think, when we're not very good at talking about our warts and blemishes, we're not all of a sudden going to become much more open about it. So I think it's going to be a real challenge. It's going to be a real challenge.
We have in Edmonton. There was supposed to be a proposed hospital in Southwest Edmonton,
I remember that.
and it recently didn't get funded, even though that originally there were plans designed for it or whatever. And the current budget from the province decided not to. Essentially, they're putting a pause on funding, and it's causing a huge uproar. I mean, obviously, had an expectation that there was going to be a hospital,
Well, there's
but
a lot.
I don't know if there is really the volumes or demand for a
Yeah,
hospital,
yeah.
and also, do we want more hospital-based care? Like, that's also an issue, right? But people have this ideal view of, like, we should have hospitals, and
Well,
hospitals are the beacon of health, and
we've let them believe that, though. We
yeah,
don't, that's the answer to everything. I mean, the
yeah,
same way with long-term care. I mean, it's pretty clear if you talk to seniors, they don't want to be in a long-term care facility. They
yeah.
don't. And yet we collectively, we build more long-term care beds in this country than probably any other country in the world. And yet our public and seniors would prefer to be cared for in their home and supported in their community, which is not only more effective, it's cheaper.
It's
But you
more
can't
cost
put a
effective. Yeah.
sign up that says this facility was built by whatever.
Yeah.
So I think we fly in the face of, I mentioned earlier, evidence when it would suggest we should do something and we're not going to do it. So,
Well, the evidence you shared earlier, actually, I didn't know that as far as, we're this, this, we're next to the United States in terms of per capita spending. And then in terms of our performance, it's not that great. I
no.
think as Canadians, and I, there's pride around that we have a national Medicare system, and other countries may not, and all this kind. And I think it's great. It's great to have pride over that. But I
Absolutely.
think sometimes maybe that's also getting in the way of having some hard conversations of looking at, like, our system isn't that great to some extent.
Absolutely. I think CIHI, the Canadian Institute for Health Information, publishes some good information, and the EU and the OECD have comparator information, the Commonwealth Fund, which shows how Canada ranks, and it's not good, and it continues to deteriorate on a whole series of indicators in health and wellness, and I think it's just. Uh, you're right. We live under a myth. I don't know of anybody who comes to Canada to look at it as an example of what to do now.
Mm,
Now they'll go to individual, like the Toronto General. You want to see about lung transplants, best outcomes in the world.
mhm,
It's ranked the best hospital in the world. You
mhm,
look at sick kids, unbelievable. You look at some of the work done in Alberta. It's quite. I mean, the stuff they did on neonatal transplants when it
mm.
first started, outstanding. So they're little bits here and there, but to turn around and say that this is a leading system isn't there anymore, and we're not.
Yeah.
And we talked about it, is that we're single payer. Well, we're not really a single payer. I mean, you look at 30% of the costs are
Out of pocket.
out of pocket,
Yeah.
and then you look at people. I mean, I've got numerous friends who a friend of mine just recently went to Quebec to get surgery in a private clinic. Couldn't get them in Eastern Canada, but could go, and they don't have any problem in Quebec providing that level of service in private clinics, or they go off to the US, or they do this or they do that. So I think the it's fine if the single payer and the system actually provides the services in a timely and efficient way, but I think the evidence is pretty clear that's not the case.
I will admit I have a hard time sort of whenever I hear, especially in the United States, when I hear criticisms of the Canadian system, because, like, for example, my dad, his kidneys failed in the 90s, and he had to do peritoneal dialysis,
Yeah,
and the system was there for him. Like, they
absolutely.
provide, they provided what he needed, and if he had to pay out of pocket, my dad was out of work at the time. He probably would have been dead,
Yeah.
honestly. So,
No.
like, I'm so grateful for the Canadian healthcare system, and that, when it's there, you kind of need it. But yes, there are a lot of misgivings as well. So it's a hard thing to reconcile for me, and I imagine for some people
Oh,
as well. But
well, and me is the same way. I mean, I had cancer a number of years ago. I was in Alberta, and I mean, the care I got at the Cross, and then
hmm
at the U and the Alec. I mean, all of these things absolutely fantastic. And I would hate to think, what a year of chemo and radiation would have cost. I certainly
yeah,
couldn't have afforded it. No, I think that there's aspects of our system that are absolutely stellar.
yeah.
And so it's not, you don't throw the baby out with the bathwater. I would say, but there there are opportunities, I think, for improvement that somehow need to be looked at, not just assumed if anybody's suggesting something that seems to be different, that somehow it's bad.
Do you think that, I would say probably in the last couple of years, there's been more attention towards, um, the private delivery of healthcare, and how, the system's becoming more privatized? Do you think that's kind of, it's blown out of proportion? I mean, obviously, like, we all know that obviously physicians, family doctors, GPs, they're all private practitioners, right? And the system pays for it, but like they're their own business, right? And they're private healthcare providers. And there's like a misunderstanding amongst the public, I think, as far as how much private health delivery there actually is.
Absolutely.
Uh, but do you think it's kind of blown out of proportion, or are you concerned about governments actively seeking to expand and fund uh, privatized delivery of healthcare rather than it being under, the Alberta Health Services of the world or the regional health authorities or that sort of thing?
Well, most of the stuff that I've seen in Canada that the private sector's involved in is, except for say cosmetic or something like that,
Yeah.
is what Kirby did when he did his kind of parallel report to Romano. He said,
Mhm.
um, private sector involvement in the public system. So, I can't see. Well, when I was in British Columbia, I mean, we contracted. I was at Vancouver General. We only had a limited number, 40 ORs that we could go use. Well, they were all busy. So
Right.
if you could contract out things like knee replacements or ankles or same day surgery, they were our patients just being the service being provided in a private clinic. I don't know why that's like, as my mother would say, cutting off your nose to spite your face. I mean, it's you're not saying that they're going to pay for this. The system's going to pay. So I think there needs to be an opportunity, and any of the stuff that I've seen that is actually they've talked about, whether it's Ontario, whether it's British Columbia, whether it's Alberta, and others, is using the private facilities to provide public services. So I mean, I think we'd be fools to say that we couldn't use that if we had the opportunity. I think the whole issue of privatizing, if you have a two-tiered system, I think is a different kettle of fish. I'm not saying that it can be written off, but I think it's going to be something that needs to be carefully thought about. You can't do this. You can't do anything like that under the cover of darkness. It just
Hmm.
isn't going to fly. People are too on the lookout for those sorts of things. But we have. I know people say, well, Tommy Douglas wouldn't have liked this or wouldn't have liked that, and I often said, well, unless you're channeling Tommy Douglas, I don't know. We really know what. I mean, he designed a system for hospitals and doctors. That was it.
Yes, that
Period.
was it. Yeah.
Wonderful
There's a
job.
whole lot more than
But
hospitals and
they've
doctors, right?
evolved a lot
Yeah.
since then. So don't pull kind of that specter. But I think there. I think if we're going to look at it in a reasoned way, it has to be in a reasoned way, as opposed to getting these polarities that if you do this, it automatically means you don't do that. I mean, you look at a country like Finland. I mean, they have both private and public, and they're not at odds with each other. They're
Hmm.
complementary too. So I think there are opportunities that we should explore without giving up on what we believe are some of our fundamental principles. But we have people, you look at the immigration into the country. We have people coming from countries now who do not come from the same belief about all of this stuff.
What do you mean?
Or well, belief like saying government provides everything.
Oh, I see. Okay.
And
Hmm.
so that we have um, um, a more egalitarian view of the world, and I think that can mean that people are willing to explore other options. So I think we'd be fools. I mean, I'm not saying I'm an advocate of privatizing. I'm not, but I think we'd be fools just to simply say, because it wasn't conceived of when Medicare was created, that it's not something that can be looked at in a reasonable way. I don't think is doing ourselves any
Oh,
good.
I know of people who are newcomers to this country be like, "What do you mean I can't pay to get that? What are you talking about? I mean, I should be able to just pay and get that service." I'm not saying that's the right thing, but I'm just saying
No,
like
no,
I
no.
think there you have a point as far as um, how our population is changing and some of the expectations of
Yeah.
folks who
Well, we
are
do in a way, For instance, workers' compensation.
yeah.
Cases that are workers' compensation often get preferred pathways for surgery.
Mm,
Well,
okay.
that's all through the public system, But it's, I mean, one would
Mm.
argue WCB has paid for it, or we've paid through it. Employers have paid for it because they know it's better if John, who's a steel worker,
Yeah.
can get his surgery done, then he's back on the job, and that's better for the economy. So I think, it's not. Well, these things are never as straightforward as you think they are.
Yeah. Yeah.
But
Yeah. Yeah.
anyway,
Yeah. Let's talk about the workforce. We know that we talked a little bit about that already, but let's dive deeper into the workforce. I was kind of doing some research into like things that people are searching just through Google in terms of Canadian's healthcare system and the workforce. And the most common thing that came up was like, how do I become a healthcare assistant? How do I become a healthcare aide? And that maybe told me that okay, there's a lot of interest potentially from other parts of the world to come to Canada and work in these professions. And we know that there are shortages in a variety of healthcare professions right now in Canada. From a, I guess, what would your um, advice or suggestions be to people who are wanting to come to Canada and work in the healthcare sector? Is it a good time? What are some things that you'd be flagging for them? Yeah, just curious about that.
well, I don't think there's any doubt that every country in the world is on the run for healthcare workers. So, if individuals are qualified, uh, um, as determined by whatever governing body it is that rules over them, then I would think the coming to Canada would be a good thing. I think the immigration, I think, is something that's going to have to be looked at, just whether how many people we can take into the country. I do worry from the point of view of stealing healthcare workers from other countries that need people. That we're leaving those people in kind of default. Now I know that's kind of a big system view, but I remember at one time the ICN, the International Conference of Nurses, kind of made a plea that not for countries not to be stealing workers from others,
Mhm.
because those other countries need people as well. So it's not that straightforward. I think there's no doubt that Canada's looking for healthcare workers in a variety of professions and practices, and all depending on where you want to go. Then people are certainly. I don't know any province that would say flat out no. They may say there may be qualifications about, you need to do this or you need to do that. I mean, to come and say, well, I want to immigrate to Canada and then I'm going to train to be an aide. I think what the country would be more interested in looking at is people who are already trained. So,
Mm.
not because if they're not trained, then one could argue you can train your own, at some point. So it's not straightforward, but I think there's no doubt that the country will be looking for workers in all of the fields in healthcare, and that's only going to get worse before it gets better. I just don't. I don't think. I looked at some of the health manpower data globally, and it doesn't matter. I mean, you can produce as many medical schools as you want and as many nursing schools as you want, things like that. But people are leaving the professions, leaving healthcare too. So the quality of the work life, are you spending a lot of money on training and education, and then they're leaving because the quality of the work life is not particularly good. So it's I mean I'm pleased that people now are spending more time looking at health manpower and health human resources. But when I my first job out of graduate school, so that was back in 1981, 82,
Mhm.
was working with the government of Alberta on health manpower planning. So
Mhm.
it has not gone away at all. And But to just think, well, we'll just beef up enrollments, and we'll change the jobs from full time to part time, or we'll do this or we'll do that. If it was that easy to fix, it would have been fixed. It is not that easy to fix.
Mm. You said something, Janet, about if someone's looking to come to Canada and get trained here, for whatever the healthcare profession is, the preference would actually be if they would have come trained. I imagine though some people are probably like, well, I have come trained. Like obviously from
Oh,
a physician standpoint,
yeah.
there are a lot of trained physicians and all that sort of thing. So maybe just square that up for me a little
Oh
bit.
no, I agree with you on that. I meant for individuals, for instance, if you're saying you want to be a healthcare aide and I'm going to come to Canada and they'll train me, I would say we've got lots of people we could probably train. I mean, the rationale for immigration would be just well, I don't know all the terms, but more of general immigrant than in healthcare because they're not currently trained in it. But I think there are people, you're right, in this country that have been trained in other countries that we actually ought to do a hell of a lot better job of saying what do we need to do to if we need to upskill them or just simply recognize their credentials. I think in some cases we get a bit arrogant about thinking that we are they can't possibly practice. I mean, I look at some physicians, for instance. Are you telling me that somebody who's fully qualified to practice in Australia or New Zealand or Scotland or South Africa or Nigeria, some of these are not qualified to practice here? What is it that makes us so different? So I think we have been a little bit elitist in our country in some cases.
Do you know if the medical associations play a role in terms of um, obviously it's the colleges of physician surgeons that ultimately license these folks, but do the medical associations play a role in potentially creating barriers for um, immigrant physicians? And I only ask because um, we've seen across Canada there's been a push to incorporate other healthcare practitioners to kind of sort of support primary care or reduce because there's been a shortage of doctors, just sort of support patients because there's that shortage of doctors. So having more nurse practitioners or other practitioners get involved. And the medical associations have been very upset about that because they're like, well, you just need to we need to support doctors a little bit more. But then I don't see an effort necessarily, and I don't know if it's the medical associations play a role in this. There are so many trained international doctors who can't get in. So like even if like the certifications don't fully align, like they're still qualified, like they're probably still qualified enough. Like there's got to be some happy medium here to get them in the
Well, I think this
system.
is where the politicians get angry, and rightly so, saying, I don't understand this. We have international IMGs, as they're called, international medical graduates, and you're saying they have to go through this whole barrage of all kinds of training and recertification, etc. Some may be required, but some may not. On scientific evidence, may not actually be required, so that we need to be much more flexible and open about stuff like that. I think there's no doubt about it. I think it's primarily the colleges that do the licensing. But if you talk about, for instance, like, well, we need more doctors for primary care and things like that. I actually think, I mean, there's not a place in the world that they don't talk about not enough primary care physicians. Well, it's the medical associations that set the fee schedules. So GPs are routinely classified as, I mean, they're on the lower end of the fee schedules.
Mm,
So you turn around and say, well, I play devil's advocate here. Well, then why don't you change the fee schedule and pay them more if you think it's so important, as opposed to just saying we need more money?
mm.
Reallocate from some of the higher paying. I know I'll get my head chopped off for that, but look at the reallocation. But I also think, and there's some work being done, I know in the UK, about primary care, unbundling it. What actually is required for primary care? I mean, we've done it in this country where we've equated primary care with an individual access to an individual physician. And people don't think they're getting primary care unless they have their own family physician.
Mm.
I'm not sure that that's necessarily, I'm not saying it may not be, but I'm not sure that's necessarily what you need. You need access to services that are timely and appropriate and all of that. But is it a GP? I mean, we have paperwork beyond galore. If actually physicians didn't have to do a lot of the paperwork, maybe they'd have more time to do, the clinical stuff that
Yeah.
they're better at. Or you look at communities. I mean, when I was in doing some work in the NWT, I met a physician there who talked about the importance of competencies as opposed to credentials. And he'd done a lot of work with the WHO in Africa, and he was saying if we rely on credentials for everything, we ain't going to get it. And he used the Northwest Territories as an example. He said, if you talk about mental health and addictions, if we're saying that in order to have comprehensive services, you need psychiatrists, you ain't going to get them. We can't get psychiatrists in downtown Toronto, let alone in Tuktoyaktuk. So, what is it that we need to have that provides appropriate services to people? And I think that needs to be, I think that's what primary care, not primary health care, primary care needs to look at. And who are the best people to do that? And some would argue they're actually the communities themselves.
Yeah. I mean, sometimes it seems like GPs are just like, sounds not great. So, but almost like really expensive triagers, right? Like, and it's like, is that should that be their main role, or can there be somebody else that can sort of help connect,
Well, I think that's a
people
good
into,
question. Are we doing this? Is what I said about the UK looking at some unbundling of primary care. What is it that they're actually doing, and is there a match between what they're doing and what they're actually skilled and trained to do?
yeah,
And I think they'd argue that no, there isn't in all cases at all. So.
yeah, yeah. Uh, from a physician shortage standpoint, though, is there something that you think that we ought to be doing that we're not?
Well, there's a lot of work going on. I think one is decluttering the work so that we that any paperwork that's mindless ought to be either eliminated or reallocated. I think this includes I mean we dithered around in this country, as Andre Picard would say, on electronic records. Where the U.S., I mean Singapore, countries like this are way ahead of us.
Okay.
This stuff is so automated now that we've got people. I mean, we actually have some jurisdictions in the country that still use fax machines, still
Seriously?
use fax to send records.
Yeah.
And so you say, what is that about? So I think there are obviously we need to look at do we have enough people? But in order to say, do we have enough people, we need to unbundle about what are the skills and competencies they need to do their job, and how are we giving them the supports to do their job, and then
Yeah.
making sure that anything else can be either deleted completely because some of it's ridiculous, but the other is that it be automated or whatever you need to do.
How do you feel about the fee models for physicians? Like, I don't, I imagine it's not unanimous across the board, but the predominant model is obviously fee for service. Um, it's a very expensive way, obviously funding physicians, but physicians obviously many of them like it. But what's your view on the fee models?
Well, I'm kind of agnostic on fee models, other than to say we need to ensure that we're paying for results. So and I would use, for example, um, somebody I'll pick an orthopedic surgeon who's doing a hip replacement on an 85-year-old woman.
Mm-hmm.
So it does the hip replacement and gets paid to do the hip replacement.
Mm-hmm.
Well, what if Mary can't walk to the community mailbox? That's an outcome that's important for Mary,
Mm-hmm.
not just having survived the surgery. So
Mm-hmm.
I think the system in some cases, we're our own worst enemies. We don't pay for outcomes. We pay for widgets or bits of things. And I think this is why I say I'm agnostic about the fee model. If we say we're actually paying for something, and we're very clear about the outcomes and the results that we want, then I don't care whether it's fee for service, blended. I mean, people
Mm-hmm.
run around and you go to these meetings where they're talking about all these different models. I think we can get lost in the models and say, no, but what is it we actually want here? And then we focus on that.
Okay, so let's take that example. That's interesting. So paying for the outcome in particular, that person who goes for a surgery, hip replacement. If I'm the surgeon, okay, I need to get paid obviously for doing the surgery. There's that sort of transaction that sort of happens there. What would be the responsibility then for the surgeon post care? Obviously, there's some immediate post operative care pieces, but in terms of like Mary not being able to walk to the community mailbox, there's a role obviously for Mary to play, right? Which the surgeon can't fully control, but maybe have an influence on. But I would imagine there'd have to be other people involved
Oh,
in the system,
absolutely.
right?
There
Like the physios or whatever, right? So,
and the
like,
community health workers, you
yeah,
name it. And I think this is one of the challenges why we haven't really gone that way, is to say, if these are the results we're trying to achieve here, then how do we develop a payment model that actually supports that? And it wouldn't just be. I mean, obviously, a component. You're quite right. Is the surgical procedure itself, or the interventional procedure, or whatever it might be. But in order to get the outcomes we want, which is that Mary is mobile and can do and returns to has got a high quality of life, those sorts of things,
yeah,
then we have to look at it in a different way. And so you
yeah.
look at comprehensive care, and they have payment models that look at that. But I think what I would say is it needs to be thought out. It's not enough just to say, well, we'll pay for this service and we'll do this and we'll do that. That's the challenge, I think, that's got us in the problems we are now is, well, we have a problem, we'll fix that, do this. Well, now we just created another problem and another
Hmm.
problem and another problem. And what ends up happening, and then the answer is, well, you need to give us more money. The fact that Mary
Yeah.
can't walk to the mailbox. Well, we need more money for physio, or we need more money for community support worker or something like that. It's like, no, wait a minute here. We need to reconfigure the funding to support what are the outcomes we really want. And we're not really very good as a system on supporting outcomes. Particularly, you mentioned earlier about population health. We're actually not good at that at all. I mean, do
So,
we
so,
really talk about improving the health of the population? No.
so funding based on outcome, though, is there a chance that somebody loses out? Like, and what I mean by that is if someone's used to a certain level of compensation
Oh,
or that sort of,
absolutely.
okay,
Absolutely. No, no,
yeah,
no, no. I would
yeah,
say this is why it's not for the faint of heart.
yeah,
And what ends up happening is that we don't do it
yeah,
because it requires, this is not about tinkering at the edges in healthcare. It's about actually some fundamental
transformations,
reforms. And
yeah,
but the thing that I find quite interesting is, and again, Andre Picard made an article a couple of weeks ago where he talked about um, um, Canada being we're a nation of procrastinators, which we are. We just push things off. So we'll do a
yeah.
study, we'll do another report, and we'll do a study, and so we don't actually. The decision is too difficult to make, so we'll just put it off. And then, of course, when it really is way too difficult to make, is when we end up having to make something, and you just create havoc.
The number of reports, right? Like you said,
Oh,
Romano report, Kirby report, the Drummond report in Ontario. Each health system has had numerous consultants address. It's crazy, and
and
yeah,
absolutely. I think I've been involved in about 6 long-term care reports,
yeah,
reviews in a number of provinces. Mental health, the same thing. And, I was involved heavily in SARS in
mm,
Ontario. And then um, when we were looking at the review post-COVID, well, SARS is a COVID, they're the same, well, a variant of the same virus. And the reports that were done on SARS, there were 3 big ones out of Ontario. They're all put on the shelf. And when we looked at, people said, why didn't we do this and why didn't we do that? It's a good question because it was recommended after SARS, that you don't move patients from one facility to another. You don't move staff from one facility to another. You make sure you have an adequate national supply of certain products, those sort of things. Oh, well, that was then, but now SARS is over with and we'll just forget it. And now, 20 years later, you have to dig it out and start again.
yeah, yeah. Another profession that I'm very concerned about are the nurses. Like,
Yeah.
I think that, it's obviously clear very post-pandemic, like the role they or during the pandemic, the role they played. I imagine there's so much burnout and the culture is
There is.
probably so negative these days. I don't know, but what's your sense, whether it's in Nova Scotia or just across the country about
Well, I mean,
the morale of nurses and yeah,
well, I don't think it's good. I mean, I often say I'm an old nurse in more ways than one, but I think it is a real challenge because they want to do the best they can. So you can imagine coming onto a clinical unit that is short-staffed. It's not short patient; it's short-staffed. So you have to deal with all of these patients. They're sicker than they've been before, ever been before, and you're trying to do your best, and there's just not enough time and not enough resources to do what you need to do. So the answer always seems to be, well, we'll just give them more money. And the unions fight for that, and God bless them that they fight for that. That's fine, but that's not. I mean, you look at what motivates people. It's not money. I mean,
no,
money will just make sure they're not demotivated. But if you talk about the things, your Maslow's hierarchy of needs, the things that really uh, energize people are the things that are not money related, and
yep,
they're the things that, by and large, employers haven't spent a lot of time on. So, what is it that really motivates people? So, are there learning opportunities? Are there promotion opportunities? Are there opportunities for development, mentoring, all of those sorts of things? It's all just kind of subsumed under the labor relations portfolio, as opposed to saying, what is it that makes people happy, not just happy in a kind of a, but feel that they're doing a good job and they're rewarded for the right things. And I think that's, I mean, the shortage of nurses globally is huge, and it's not getting, I mean, fine, you produce all these nursing schools, but that's only a drop in the bucket,
yeah,
only a drop in the bucket. So I really, no, I think they're really at the core of the system, and without them, I mean, I was at some meeting last year where somebody said by the year 2030, the world will be short. I don't know how many million nurses. And then the speaker's comment was, and we ain't going to fix that overnight.
mm, hmm from a workforce crisis standpoint, what are some takeaways that maybe you want folks to walk away with from a maybe solutions perspective? Like, what do you think are some um, I know again we just talked about these aren't short term things that we can like we can't fix these things overnight. But what do you think are some things that we ought to be focusing on from a workforce perspective
Well, I
to
think
kind of
it's really listening to our staff.
yeah
I mean, one of the things I've often found is, people say, well, you don't really like to do too many staff opinion surveys because they're going to demand all kinds of stuff that you can't give them. Well, in my experience, when you do those sort of surveys, that's not what they're looking for.
mm,
But you need to be able to you want to you need to work with your staff. What are the big issues? What are them? Not the money issues, but other things, and what can we do about it to help? I mean, for instance, there was some great stuff done in the UK a number of years ago, what they called releasing time to care, and there's some stuff that's happening in Canada like that as well. So, what is it that makes their job more difficult? And they said, well, for instance, a clean utility room is way at the end of the hallway.
yeah
And every time I do try to change the dressing, I'm running back and forth, back and forth. Well, then create some smaller utility. That doesn't take much time. Or you portable, utility carts that can be moved from room to room. So, looking at where you store things, what you do here. There are a lot of very, very practical suggestions. I mean, we're doing it here. Our premier and the minister have gone out on walking and listening tours where they, say, what do you think about this, or what are some suggestions you have? And they're common sense sort of things, which I think, you'll never know till you ask people. Quite
hmm
frankly.
that's actually one of the things that I don't know fully how the engagement process or if there was for some of those big reports in the past, but I know for some of them, I think there wasn't very much of an engagement. It really just was like those experts kind of and their commissions kind of writing this report without actually asking what people want or think. And I think that from a healthcare perspective, that's naturally going to fall short.
Oh, I don't disagree. I'll play devil's advocate, but the problem, if you ask people a question, they'll give you an answer.
Mm,
If you don't want to hear the answer,
yeah.
then you shouldn't. And I think that's bad. I mean, all the way around. But no, people assume, and healthcare is particularly paternalistic about that, more than a lot
Hmm.
of industries are. Whether it's patients, well, we're going to operate in the best interest of the patients. Well, how do you know? Well, we do that. Well, no, ask the patients what they think. They may tell you
Yeah.
something quite, and it doesn't mean putting a patient on a committee that decides what color of paint you want to paint the doors in a lodge or something like that. It's meaningful input. And I think that takes effort, and it takes genuineness, and that's not something that's easy for some people.
Well, even if you don't fully take their input, it creates an environment of trust, right? It creates
Absolutely.
it creates an opportunity for them to feel like they're bought into the process,
Yep.
and they might not agree with what you say at the end of it, but at least they feel like they were heard, and that in itself
Of
is
course.
so important these days.
Absolutely. And it also gives you an opportunity to explain why you might not want to do something.
Hmm. Yeah, that's a good point.
Yeah.
Yeah. I know we're at the tail end here, but when you think about Canada's health crisis, are there any other things that you um, feel that are just really concerned about right now? So we talked about the workforce. We obviously talked about from a prevention, health promotion standpoint, a lot there. We talked about leadership at the front end. We talked about morale and culture. But what else is on your mind from a Canada's healthcare crisis standpoint?
Oh, I think it's a lack of integration. Everybody's doing their own thing, trying to come
Yeah.
up with a solution to fix something. And I just think that creates more disintegration and more dysfunction. And I do worry about that. I mean, I don't, there's not a day goes by that I'm not reading something that the wait lists are longer, the quality's worse, the cost is higher. It's quite frightening, actually. I mean, I I've never heard so many people talk about the fact that they don't think the system's going to be there for
Hmm.
them.
Hmm.
I've never come across that in my career. Never. That
Yeah.
people actually worry. I mean, you'll see people, they'll worry about where they're going to actually live in Canada based upon on what the system is like in that city or that jurisdiction. So that worries me that we'll fiddle around, and I don't mean to denigrate the efforts, but and the system is just slowly deteriorating.
We were talking about this before we started recording, where you're at in your career, and you feel like you're at a point where you can just be a little bit more straightforward. And is there anything that you feel like you haven't been able to maybe communicate that is just sort of burning inside there, Janet, at all? Or
No, I mean, I think I've said pretty much all I have to, except that the platform is burning, but it has to be. It's not kind of there's not an easy just one fix for this, and that's
yeah,
what worries me is because it's so. I think healthcare has become inherently politicized at a level that it's never over my career was
yeah.
so political as it is now. And in some ways, that's good because you've got the interest of the politicians. But interest doesn't mean they should be running it. And that does worry me a bit that that they that there's a feeling that politically they can run the system, and I don't think that's the case. So I would guess that would be about it.
Do you think that that reflects though a desire from the people? Like I know generally, if you ask, I imagine if you ask somebody, do you want the politicians running your healthcare system? Most people are going to say no. But there's also this, I imagine there's also this expectation, like obviously during election, people are campaigning on healthcare and all this kind of stuff. There is an expectation that they voted for that party because they're going to get something done on the healthcare system. So they can't just passively just
Oh
watch
no,
things
I don't
happen
think they
either, right?
should.
So
I think, I mean, I look at our government here was elected on a healthcare platform. That was their only platform, and that's they've really focused on that. But it's not getting into the details. It's not the premier or the minister getting up and saying, "Well, you're going to do this, you're going to do this, you're going to do this." They set some very specific outcomes that they want to achieve, and there's an action plan for health, and you focus on that, but not deciding all the details. I think that's when you get into that level of micromanagement. I think you get into real difficulties, because you might fix an individual problem, but you may create more. Well, as we've talked over this last hour and a half,
Yeah.
it's not one silo.
No. Yeah, for sure. Jen, are you okay if I ask you my last two questions I ask every guest?
Yeah.
Okay, so 5 for dinner question: dead or alive, who are 5 people you'd want to have dinner with?
Well, I was trying to think about that. I think the 5 I would pick, one would be Anthony Hopkins. I just think he's a brilliant actor, but
Yeah.
he's also quite an artist. And I'm a big fan of art. Marshall McLuhan,
Okay.
who did the Medium is the Message. He was
Okay.
actually a professor of mine at Windsor, an undergraduate, but really talking about communication and the importance of communication. Agatha Christie, just because the whole understanding communities and people.
Hmm.
Clayton Christensen, who late of Harvard, who did all the innovation stuff. I think he's brilliant. And finally, Siddhartha Mukherjee, who's he did the Pulitzer Prize winning book back in about 2017, the Emperor of All Maladies, and the Emperor is the cancer. And then his most recent book is The Song of the Cell. So those would be the 5.
I feel like that professor still around?
Who?
The
Mukherjee?
no,
Oh
the
no,
second.
Clayton Christensen.
Yeah.
No, Clayton died about a couple of years ago.
Okay, because I was
He
gonna say I
wrote
feel
his.
like that one would have been a realistic one for you to maybe actually have supper with.
Oh no, absolutely. And I met him when I was in Toronto one time. He
Yeah.
wrote the book The Innovator's Prescription. His stuff about innovation was really quite something, where you have to literally go outside of the box to do some stuff, and he was
Yeah.
just great.
That's fantastic. That sounds like an awesome 5. Last question: besides the circle of life, what do you know for sure?
Well, it was interesting. I'm reminded of a statement my mother made once. She said, as far as she knew, you only go through this life once, so you better make the best of it while you can. And I think that would be the other thing. Would be to, I'm only here once, so I better do what I can while I'm here.
Well, on that, Janet, the amount of contributions you've made to our healthcare systems across the country is, I think it's easy to say it's profound. Like it's incredible the amount your body of work and the diversity of your experiences. And like I said, talked to a few people that I'm talking to Janet Davidson. They're like, "Holy smokes! Like that's amazing. That's
Well, it's good.
they're looking forward to this conversation." So it's truly been a pleasure and an honor. When I was my connection with you was very indirect, but I was an intern at Alberta Health and you were my deputy. And coming into government, I came into government because I wanted to make a difference, and I still feel that way working
That's
in
good
the
though.
municipal level right now. But to know that kind of almost to some degree a little bit full circle, I'm like, here I'm talking to my former deputy. Like you look at those deputies, you're like, man, those are those leaders that you
Yeah.
aspire to model and emulate. And I remember when you first came to Alberta Health, I think it was just after you were at AHS, and I'm like, yeah, this person has so much experience. And so anyways, it really is an honor to be able to talk to you. I really appreciate your insights. They're very candid, straightforward, and a lot of wisdom behind things. So thank you so much for making time for me today. I really truly appreciate it.
Well, thank you very much. I very much enjoyed it and talking to you. It's good.
Thanks, Janet.
Great.
Thanks everyone for listening to this episode. Like, subscribe, and share it, and we'll see you at the next one. Cheers.